Hello, everyone. I am Danielle Willis. I go by Danny, and I use she and her pronouns. And I'm a senior instructor in the School of Social Work here at Colorado State University. And I have the privilege and opportunity to work alongside the Inclusive Health Collaborative as the social work kind of clinical connection. And this video is brought to y'all by the Larimer County Behavioral Health Grant, which is super exciting. And today we're going to be talking about adverse childhood experiences. Okay, so we're going to do a map of where we're headed today. As you all know, a trauma-informed technique and tool is to guide those we work alongside, those that we serve. So this is an opportunity to model that. So today what we're up to is we're here for about a 15-minute chat about what are ACEs. But in order to talk about ACEs, we must talk about trauma first. Then we must talk about the data from that. And then what do we do with that information, our awareness and prevention opportunities. And again, this is the roadmap for what we're doing today. And that reduces anxiety for everyone. And we want to do this for those we serve as well. Okay, so today we are educating, we're engaging, and we're empowering. So I have some disclaimers. And as I look down at notes, forgive me. But I am not an expert in this topic. Honestly, I came to this work through my work with substance use, harm reduction, and public health. And so I have kind of found my way to trauma work, understanding why we use, right? Understanding why we struggle with mental health. Those are the bigger pieces to that. I do have a license, clinical social work license, and I do have a licensed addictions counselor certificate as well. So that's what I can bring to y'all. But in the end, where we'll end this training is we all have a role with trauma awareness connection in our communities. We must show up to change things. We must show up to be aware. I have limitations in what I can and cannot do as a social worker, right? We need a full community on board to support this. So this is going to be a quicker version of that 15-minute chat. We won't be able to dig into things as deeply as I would prefer, and understand that y'all can reach out with questions. Last disclaimer is this content can be heavy. It can be triggering. We can be reactive because guess what? We're humans too. Us who provide services, us who are learning about who to provide services, such as students, we're humans too. So I encourage you all to reach out to your support systems, reach out to those that you work alongside, and reach out for help as needed. I will be mindful to not dig into that, but just an awareness on the conversation. All right, so to give us a framework for what we're up to, we have to understand the layers of intersection when we're working and talking about trauma. We want to be mindful that today we're focusing a lot on how ACEs link to those insecurely housed, right? How ACEs link to those homeless, how ACEs link to trauma, how ACEs link to substance use, mental health, socioeconomic status or poverty, and race and ethnicity. We're going to be intentional to be mindful of the intersectionality of all these pieces when we're talking about ACEs and trauma. Nothing can be pulled apart. And me as a social worker, I see everything through these system lenses and the understanding that they're all connected. And I ask you to walk along that vision with me. So we're also going to use person-first language throughout this conversation. It's essential that then when we go back into the work after watching this video, and hopefully y'all will engage with the social determinants of health video from Paula Yuma, and you'll engage with my trauma-informed care video that you can watch next. But we need to use persons-first language, meaning we are going to let the individual that we're working with deem how they would like to be identified, every piece of that, right? And when I use persons first language with those who use drugs, we often say people who use drugs, for example. In general, those who we might in data identify as homeless might not identify that way at all. So that's why I often prefer to use the word insecurely housed. When it comes to substance use, I prefer to say substance use spectrum instead of saying substance misuse or substance dependence or substance abuse. Those are all not particularly helpful because it can create distance between those we're walking alongside. In our role with IHC and in our role with supporting those insecurely housed, we need to let the client self-determine. So without all of those disclaimers in mind, the impacts of an understanding of developmental trauma is essential. So we'll dig into that. The ACEs discuss exactly that, developmental trauma, that occurs between 0 and 17 or 18. And we must understand this to improve the community through any service role that we have, from front desk staff to volunteer role to how we show up as a medical provider or social work in a clinic. So what is trauma? Trauma has a few different definitions. I honestly don't want to get into the DSM definition, but I must put it up here for y'all to understand. There are PTSD, post-traumatic stress disorder definitions in the DSM-5. What I really want to talk about with us today is a bigger, broader perspective. And Dr. Bruce Perry does a nice job at explaining what is trauma, right? Individually defined is different than that DSM definition. It should no longer be pathologized. Dr. Perry's big push is moving away from that pathologizing of trauma to understanding trauma as, what do you expect? Trauma happens everywhere. We all have indicators of trauma, and we're all on that spectrum. And so kind of changing the language and changing how we see it. And in my work, we call that the social construction behind what we're doing. So what do we expect? Things happen. And what do we expect? Yes, trauma occurs. So when trauma happens, we have to think there was an event of itself, an incident, then how that individual experienced that event, right? On that person, how it was experienced for them, different for everybody, different for me than for you. Then the effect of that. Did the event activate your stress response system? And that's where the brain comes in, right? That's where it comes into our physiological system as well. And overall, the pattern of activation of your stress response system, that leads to overreaction of that system over time. And that's where trauma becomes more chronic. So I want you to frame everything we're talking about from what do you expect? Things happen. We're not going to have a pathologizing view. We're going to have a normalizing view of trauma. Note that to normalize, we have to understand that trauma comes from 4 different complex connections. Comes from links to the brain, how the brain responds, right? That response system, which I'll talk about. How our automatic response systems happen out of the brain, still connected. Epigenetics, which is like our gene expression and how that changes over time. And attachment. Attachment is very much affected by trauma and our developmental trauma over time. I'm sadly not going to be able to dig into epigenetics and attachment as much, but I just want you all to know it's just like everything. There are layers connecting to how trauma comes and how it becomes complex. So to think about it, Danielle Siegel has a wonderful whole brain child book that I want you all to check out. But Danielle explains the hand model of the brain. So we have our upstairs brain and our downstairs brain, right? Our upstairs brain is that prefrontal cortex where we're thinking and reasoning, right? And our brainstem manages all of our response systems. And sometimes what happens when our prefrontal cortex goes offline, we flip our lid and we're in an activated state. And those of us that have had trauma are often into that activated state, maybe more quickly, more rapidly, or maybe more inconsistently. We see this all the time with kids. Danielle Siegel writes a lot pertaining to how to help and support children. I love it for this context. So just remember the hand model of the brain. When we've all flipped our lid, right? When we flip our lid, we've lost our prefrontal cortex. It's no longer online. We're only running in response. We're only running in those base systems. So this digs into it a little bit more with the amygdala, right? A normal function, it sets off fight or flight responses like normally. But then when we have post-traumatic stress or that trauma we're talking about, it sets off fight or flight in response to memories, thoughts, situations. When we walk into a clinic and we don't know, we've never been there before, it could flip our lid right there, right? We must have awareness to this. We must acknowledge it and understand the prevention opportunities. So that prefrontal cortex here, when we have that trauma response, it's not functioning correctly, right? We can't make decisions. I always say when someone has flipped their lid or we're going into that trauma response place, we really can't hear, learn, listen, or be. We've all felt that at times. So I challenge you to tap into your empathy to tap into your understanding of when you flipped your lid, when you felt dysregulated, and how we can't think in those states. So we need to be mindful of that when we're in clinics, when we need to be mindful of that when we're seeing animals or humans, right? That sometimes that human involved in this has been responding to something. Something else is going on for them. Okay, so the automatic responses. We've heard this, I'm sure y'all have heard this, but the flight response, we run away. The fight, we become defensive or aggressive. We can see this all happening in clinics, in medical setting, and social work services. We see this everywhere. Freeze, we're just shutting down. And fawn, which isn't talked about often, but often a trauma response is to fawn over something because it works. Fawn over your provider, fawn over someone else because it works. So to make this very clear, we need to think about epigenetics, but I won't be able to tap into it too much. But our genes, right? And proteins in cells basically are affected by our environment. And over time, our traits change. So meaning that we carry genes, expressions, regulate ourselves, and resiliency is found in this, but also stress responses found in our genes. And they truly change over time with generational trauma. Attachment must be noted because I think this is the key point for successful repair work that we can do with those that we serve to be more trauma informed. We'll get into this more with the next video, but I want you to be aware the power of attachment, right? The foundation of how relationship matters. And trauma is like a virus, like this picture in our systems. And we are going to be mindful that that virus can be supported and addressed through attachment and connection, because that trauma makes disconnection lend to it very easily. So what are those ACEs, right? This is the most critical point of the talk, obviously. So ACEs are adverse childhood experiences. Yes, ACEs, adverse childhood experiences, or ACEs, are potential traumatic events that occur when we're little, 0 to 17. They're also included in aspects of the children's environment, right? Stability, bonding, and belonging. There are 10 questions that the ACEs are made up of, okay? You'll see this picture on the right that explains those different pieces. I'm not going to go into each 10 questions because it's not recommended that we self-assess. That's not helpful to screen and assess without support and intervention. So I want to encourage you all that it's not particularly recommended. But this study was done in the 90s, and it was done primarily with white individuals predominantly, and that is a limitation of the study, which we'll talk a lot about access to care. And we know BIPOC communities often are not having access, and that showed up in this study quite a bit, especially in the 90s, with white Kaiser patients in California. They were asked 10 questions, and each 10 questions surrounded physical abuse, emotional, sexual, neglect is a little one, emotional neglect is a little one, and then those household pieces from an incarcerated family member to substance use around them, divorce, mother treated violently, and mental health overall. This again talks about those layers. So with ACE study, we know again, produced by Kaiser, asked all of the adults these questions from when they were young. And the original ACE study ran from 1995 to 1997, and over 17,000 members received this while they were getting their physical exams. And those demographics, again, about 75% white, 46% over 60. We can imagine the limitations here. The data that came out of that is so fascinating. The data is essential that we talk about because look at this. There's a linkage. We know the higher ACE scores that someone might note on that assessment, the higher up we go on this triangle. So, right, we go all the way up to early death. So it links us to even the social determinants of health, okay? So we have to understand health risks come from this, social risk comes from this, housing risks come out of the ACE study, and the more ACEs indicators you have, often the more challenges. It's a great visual. We also know the impacts of ACEs come to behaviors and then our physical and mental health. So this visual is great for talking about the lack of physical activity that can come the more ACEs we have, smoking, substances in general, from alcohol, drugs, to not being able to work, to the physical and mental health, from our obesity to diabetes, right? To depression, suicide attempts, STIs, heart disease, cancer, stroke, COPD, and broken bones. Linkage throughout from higher ACEs to higher behaviors and physical mental health. So here's a few more numbers for y'all. Okay. So we have zero for what the study actually did then in the 90s was 0 ACEs, right? We saw women at 35%, men at 38%, okay? And then we went up to 4 or more. We saw women up to 15%, men up to 9%, and total up to 12%. You see a significant kind of notching up. So then what we know is this study revealed a strong dose response between the relationship between childhood trauma and adult heart, lung, and liver disease. Obesity, diabetes, I said, depression, I said, substance use, and STIs throughout. So this is a great visual kind of showing the linkage, but those adverse childhood experiences linked to our educational reduction in opportunities. It links to higher risky behavior, more chronic disease, more infectious disease, which is again often what brought me into this work, more maternal health struggles. You could think about that for the epigenetic side of it, more depression, anxiety, and suicide, and traumatic brain injuries and fractures and burns. So just those accidents that happen. Okay. So here's a good last visual to just show the more ACEs, the more impact from those life health pieces, behavioral pieces to life potential. And compared to those with 0 ACEs, those with 4 or more are at least 3 times higher rate to use alcohol, 3 times higher rate for depression, 2 times higher rate for lung and liver disease, 11 times higher rate for injection drug use, and 14 times higher for suicide attempts. Startling statistics, okay? Even if we negate some pieces of the limitations of the study, which we'll talk more about, startling information. So the CDC data, and I want to link this truly to our housing insecurity that we're talking about for the population we're serving here. But ACEs are common, right? About 61% of adults served across the 25 states. So this is outside of that original study. Across those 25 states reported that they've had experiences of at least one type of ACEs. Nearly 1 in 8 report they've experienced 4 or more types of ACEs, okay? So we know that preventing ACEs could potentially reduce large numbers of health conditions, that some children are at greater risk than others, and ACEs are extremely costly, extremely costly. So back to some children at greater risk, we know that those children of color are at a huge risk for experiencing more. And part of that might be systemic pieces of reporting, and I want to be mindful of that. And part of it is truly our social construction and our society around racism. So ACEs are costly, right? The economic and social costs are there. So on the side to think about housing insecurity, okay? Children living under the federal poverty line are 5 times more likely to experience more ACEs. Again, my disclaimer around what's being reported, but in general, research suggests that health consequences of high ACE scores are often complicated by lower socioeconomic status and being insecurely housed. Children experience homelessness, frequently have caregivers with untreated mental health, and on that substance use spectrum, which we know higher potential for developing post-traumatic stress, and it's nearly universal for that post-traumatic stress. Children at risk for neglect were significantly more likely to be from families insecurely housed than those, and those mothers reported higher stress while pregnant. And we can think about the epigenetics piece there. Nearly 33% of children experiencing a lack of housing stability have a parent who's incarcerated. Again, we can think about that intersectionality, Kimberly Crenshaw, understanding that there is no simple way to tease any of this apart, which is what brings me to the work, those complex systems. We know that up to 21 million cases of depression could be reduced if we could get under control our ACEs. up to 1.9 million cases of heart disease, and up to 2.5 million cases of overweight and obesity. So there is a systemic connection here. ACEs can have lasting negative effects on our health and well-being, as well as our job opportunities and potential. ACEs are associated with our social determinants of health, which we've said, such as living under-resourced, experiencing racism, experiencing food insecurity, and other things. Some children may face further exposure from historical and ongoing traumas due to systemic racism, and they're finding over and over again that microaggressions that are happening are leading to big T traumas, impacts of that lower socioeconomic results. So the limitations of the ACE data, big time. We've already touched on this, but we know those demographics were limiting in itself by being 75% white and older adults. So we know that original study has limitations. We know there's lack of that BIPOC representation and less educational levels. And again, that research has shown those microaggressions lead to big T trauma, and also not enough notes around the gender spectrum. So what do we do with all this? Okay, so we know trauma is there. We're normalizing it. We're talking about the 3 E's. We're thinking about it separately. We know ACEs study happened, and it truly showed to us the more ACEs we have, the more linkage to behavioral, social, and long-term physical outcomes are true. It's just there. Trauma and stress lead to physical, social, emotional, long-term behavioral pieces for us. It makes sense to me as a social worker. I'm sure it makes sense to you all if we tease it apart like that. But what do we do with it when we're working at the front desk, when we're serving in a clinic, when we're a medical provider or a veterinarian? What do we do? I think the biggest pieces here today, and I hope you take away, are awareness, okay? We can do something about this by developing awareness and prevention. So our awareness is we can reduce our health conditions. We can reduce depression by 44% if we just address some ACEs, right? We can reduce chronic health conditions if we address this. We can significantly reduce health risk behaviors, healthy risk for taking behaviors like smoking and drinking, if we're talking about ACEs early and we're doing prevention programming and normalizing trauma in general. We can address socioeconomic challenges with unemployment and less education and health insurance by addressing ACEs. So my challenge and my notes are around awareness. Awareness changes the game and allows us to understand that trauma to be normalized and understand that is our role in the medical helping situation to serve this. I, as a social worker, get to see some people for just a minute, right? We need everyone on the team, right? We need to be in this together. We're aware ACEs are happening. We're aware we can prevent, we can reduce, and we can do this by support and relationship. We can normalize this and we can reduce stigma through the ACE study. That's what's really powerful about it. We can understand that those microaggressions or smaller developmental traumas lead to the big T traumas. So it's essential that we are doing our own work. And ethically, we cannot just screen individuals with their ACE assessment and not follow up with interventions, referral to treatment and support. So that's essential. We need to remember that trauma is always present. It's kind of the idea that rattlesnakes are everywhere. They're there. They're not going anywhere. And our job is, as providers, are owning how we show up in the room, how we guide, we give that map. And we'll dig into that more with our trauma-informed care. Trauma leads to disconnection. So Bessel van der Kolk explains from The Body Keeps a Score that we must all address trauma because the therapists, right, they only can do a small piece. We in the community can do everything. So the rat park idea is that there was a study a long time ago that if rats were in community, they wouldn't use substances at the rate that rats in isolation will use. And so our job is to bring community to those that we serve. Disconnection leads to depression. Disconnection leads to anxiety. And we need meaning in the work, school, and our values. And we need community support and nurture in nature. So connection is the opposite of addiction. So right there, we're linking all those ACEs. What can we do? So if you identify as a healthcare provider, what can you do? You can identify current risk for ACEs in those that you serve and refer patients to effective support. You can link adults to family centers, treatment approaches, substance use treatment, and or parenting interventions. You can ask your social worker, you can do this together. We can provide support and services. What can employers do, right? If you identify as a supervisor or an employer, you can develop and support family-friendly policies, such as some paid leave for those that you support, and flexible work schedules. So again, we're reducing and preventing those ACEs. We're reducing and preventing them early through healthcare. We're reducing and preventing them early through employment. What can we do with the states, what us as a state or a community can do, all of us? We can improve access to childcare, right? By expanding eligibility. We can use evidence-based social and economic supports, right? To reduce those hardships. We can enhance connection for caring adults and increase families. That's a referral. That takes 90 seconds of connection in the room with someone to change how they'll walk out the room. So if we say we don't have enough time, the research challenges, we do have enough time. What can everyone do? We're going to recognize this. We're going to understand and normalize trauma and challenges that families face. We're going to support programming, mentor programming, kind of that Boys and Girls Club. We're supporting all things, grow groups and programming for our youth. My challenge to you all as providers is to show up in the room, give good eye contact, connect for that 90 seconds, normalize that trauma is a piece, the ACEs study is real and effective, and that my challenge is that to challenge the systems you work within, bring awareness prevention to your role, because those that are unstably housed or identify as homeless deserve to be seen and heard, and they may have more ACEs. We don't know for sure, but we need to understand and assess for that all the time. And I challenge you all to watch the next training video on trauma-informed care so we can dig into more how to best serve those unstably housed. Here's a list of lots of references for you all, team. And please reach out with questions. I give you a great thank you for listening and understanding. We're doing the best that we can. I appreciate y'all. I notice y'all reach out with questions through email. Take care. Good work.